So today, I would like to share with you a topic of how to combine the transvaginal ultrasound and hysteroscopy as an office assessment in infertility women. So my talk will start with a little bit background of myself. So I work in this hospital, Cipto Mangunkusumo Hospital. It's a national referral hospital in Jakarta, the capital of Indonesia. So it's in side by side with this Faculty of Medicine, Universitas Indonesia. If you look at the background building, it's a new building. We have an Indonesian Medical and Education and Research Institute, or IMERI, where we have clusters on research in medical science. So in daily basis, I work in this clinic. It's a gynecology center where we run our clinic, and we also have our OT to do an ambulatory surgery there. So our services includes family planning, fertility assessment, endometriosis assessment, urogynecology, and gynecology ultrasound. So let's see how I do my practice every day. So here is the procedural room where I put my ultrasound and the office hysteroscopy side by side. So by combining these two, we can see many advantages coming from this combination. This is the situation. You can see the patient there. Look at the monitor by yourself. So this is a case of difficult IUD extraction, where we use the office hysteroscopy combined with ultrasound to do the extraction. We also have this operating theater for an ambulatory surgery, for simple cases in laparoscopy, and also cases for operative procedure, operative hysteroscopy. Here, for instance, we use the shaver for intrauterine mass. So let's start with our main topic. So how to do an office-based assessment in fertility. From ACOG committee opinion, the basic workup for fertility consists of history, physical exam, and pre-pregnancy evaluation. And additional evaluation consists of ovarian reserve assessment, ovulatory function assessment, tubal fracture assessment, uterine fracture assessment. If you look at each of the assessment, for instance, ovarian reserve, we can use anti-mullerian hormone, AMH lab, but actually in our daily practice, we can just use the transvaginal ultrasound for looking at the follicle antral count, the endometrium characteristic, the thickness, the shape. And by looking at that, we can also assess the ovarian reserve. The ovulatory function, by looking at the follicular growth and tracking using the transvaginal ultrasound, we can also assess if there is an ovulatory problem. Tubal fractures, usually, classically, we use the hysterosalpingograph, but recently, and me, myself, and my team, now we change this practice. We use transvaginal ultrasound and also office hysteroscopy to assess the tubal fracture. Uterine fracture, of course, we can use transvaginal ultrasound as our first line, and we can, for sure, we can use the hysteroscopy to see especially the intrauterine or intracavitary pathology. So let's see one by one of this. Why we combining this hysteroscopy and ultrasound? Because by combining this, lots and more detailed fertility-related pathologies can be diagnosed, and not only diagnosed and treated, since hysteroscopy has a see and treat fashion capability, right? So what we do here, patient can come in any dates in their menstrual cycle. And usually we just need one or two visits from the couples to assess all the possible causes of their infertility. For ovarian reserve, we can use any days. Ovulatory function, usually during the mid cycles up to the secretory cycles. The tubal fractures, usually we do it in the late proliferation phase. And uterine fracture, we can do it all cycles. Male features also, we can do it in all cycles. So by looking at this, usually we advise the couples to come to visit us in the, usually in the late proliferation phase, in day 9 to day 12 or day 13 before the ovulation. And the other visit will be in the secretory phase to see the quality of the ovulation. So by 1 or 2 times visit, we can have a quite complete assessment of the fertility. Of course, we use the transvaginal ultrasound as our first line. So this is all what we know already, how to use the transvaginal ultrasound on assessing the uterus factor, position, mobility, dimension, the presence of fibroids or adenomyosis, the Doppler assessment of uterine arteries, Mullerian anomalies, endometrium, the thickness, morphology, polyps, Doppler assessment of the subendometrial vascularization, and any pathology in the cavity. The ovary itself, position, the mobility, morphology, this is important, the accessibility when we do the oocyte retrieval, the volume, any kind of cyst or pathology, antral follicle count for the ovarian reserve, blood flow, and follicle tracking. We can look at the dominant follicle, the dimension, and the vascularization surrounding the dominant follicle. Fallopian tubes, we can see several ways how to assess the fallopian tubes using the scan and combining with the hysteroscopy later. All right, now this is the basic ultrasound scan where we can see the shape of the uterus, the endometrium, the cervix, the mobility, the any addition with the surrounding tissue. Right? We can also use the 3D ultrasound to see the cavity. Usually the Mullerian cavity anomalies will be easier to see with the 3D ultrasound. And the endometrium characteristic, we should see the correlation between the cycle days and the appearance of the endometrium. We know that in the early proliferation phase, late proliferation phase, and the day of peri-ovulation, we can see the triple layers of the endometrium and the changes of the morphology after the ovulation. And lastly, of course, the ovaries. Yeah, we can see the antral follicle counts, left and right side. Is there any adhesion to the uterus in case of superficial endometriosis, and any pathologies that we can find very easy with transvaginal ultrasound. This is the case of where the ovary is quite small in diminished ovarian reserve, and we can also see some pathology in the uterus. It's an adenomyosis, and the ovary is stick to the uterus. So when we found the ovulatory cycles and normal tubes from the hysterosalpingography and normal uterus from the transvaginal ultrasound and normal semen analysis, then we define them as an unknown infertility. But as a matter of fact, the normal uterus or normal ovarian structure that we have assessed is actually not really detailed only by transvaginal ultrasound. Why? Because we know that transvaginal ultrasound is very powerful on looking at the intramural pathology, myoma or adenomyosis or adnexal mass, but some structural pathology is not easy to identify only by ultrasound. For instance, internal osynechia, distorted of the cervical canal, small polyps, endometritis, intrauterine synechia. In these cases, actually, we need hysteroscopy to define that there are no structural pathology. So I think we need to redefine what is unknown infertility by incorporating this hysteroscopy into the assessment. We know that by doing office hysteroscopy, in our place, we do it in office setting without anesthesia. So starting with the cervix, the quality of the mucosa of the cervix, is there any sign of infection or inflammation? Then we come to the cervical canal to see if there is any pathology, especially the distortion of the anatomy or the stenosis of the internal os here. Then we come to the cavity to see all the shape of the cavity and the endometrium layer. Is there any pathology intracavitary? And both tubes can be seen. And we add some assessment of the tubes by adding some, we call it as a bubble test. So combining this with ultrasound can give us more advantages compared with only one by one. Okay, by transvaginal ultrasound, we can easily find this adenomyotic uterus, for instance. This is a small submucous myoma. Yeah, it's quite easy to look at it. But how about this? This is a polyp. Endometrial polyp, sometimes it depends on when you do the scan. If you do scan in a correct phase or correct timing, especially in the proliferation phase, it's quite easy. But when the patient came in the secretory phase, sometimes we will miss these polyps. This is a case where we found a subendometrial cyst. Probably it's a endometriosis cyst, subendometrial here. Then we do directly with hysteroscopy to see whether there is a correlation or relation with the cavity, the endometrioma. When we look inside at the surface of endometrium where the endometrioma located, we can find lots of vascular, and we open the endometrioma, and it is true that containing chocolate cysts. So we do a biopsy to check the pathology, and the pathology revealed that it is an endometriosis tissue. Here we also do a bubble test to check the tubal patency. And after the hysteroscopy, we could see the changes in the free fluid found in the Douglas pouch. That's also one sign of the tubal patency. We can use this approach to see the tubal patency. Endometrial polyps, as I said before, sometimes we miss it if the timing is not correct. But by hysteroscopy, it's very easy, and we can do it directly to take the polyp out with the scissor. Internal os stenosis or cervical canal stenosis is, I think, one of the most underseen pathology in our cases. At least in our cases, we found quite many, almost 10 to 20% of infertility cases. We found this stenosis. This is one examples of the cases here. Here is the stenosis of internal os, and we can just pull it by the scope, and we come to the cavity. Then we need to see if there is an infection in this cervix, and we need to treat them. Here also another case of cervical adhesion, some synechia. It could be caused by infection also here. And mechanically, we can just push and we can release this adhesion without any energy to avoid any recurrence of adhesions. This is quite often we found that the internal os is very small. We can use our scissor to open it, or we can use also the grasper to open the stenosis, right? This is without anesthesia. And there you go. We can go to the cavity. And finally, we can see that there is a submucous myoma. Submucous myoma here, very big. Is it type 0 or type 1? Here we can see other myoma. Actually, there are two myomas here. One is type 0 and the other is type, maybe it's type 2. So in this submucous myoma, especially the submucous, because that's the one type that really altered the fertility function. This is the other myoma, it's easy. So hysteroscopy really needed in defining what type of myoma, especially when we want to proceed with the management. We have LASMAR classification or step W classification. Do we choose the hysteroscopy for management, especially for the low complex hysteroscopic myomectomy, or we need to change it into laparoscopy because in a high score, hysteroscopic approach is not recommended. So that's one of the important role of hysteroscopy on submucous myoma. Here also another situation where we often miss with only transvaginal ultrasound. That's endometritis. Yeah. In this endometritis, we can easily find with the hysteroscopy. We can also do the sampling, right, and treat it accordingly. Uterine septate, you can easily find with the ultrasound. But combining with hysteroscopy, not only we can diagnose it better, but we can directly do the management by using a cold scissor and combining with the transabdominal ultrasound. Also, we could assist our approach in hysteroscopy not to injure the myometrium. We can also see the tubal os as our indicators in the correct plane to do the septum excision. Here, after the procedure, we can see that the distension media that we use in office hysteroscopy could also act as a saline infusion sonography. So we can see whether the septum is totally repaired, and if there is still some tissue that we need to cut, we can go back with the hysteroscopy and finish the procedure. Now we come to the tubal assessment. In fertility scan using ultrasound, in assessing the fallopian tubes, there are at least first we need to rule out the hydrosalpinx and the patency using any kind of way with ultrasound. This is the classical appearance during scan. First is the fluid inside the tube, and when we found fluids outside the tube. These pictures, fluid surrounding the tube, we can have this kind of picture after the hysteroscopy. Assessing the tube after hysteroscopy, if the tubes were patent, we can see the tube and the ovary more clearly with the saline media distension. Why this is important? Because we know that only hydrosalpinges that is seen during ultrasound that has a big impact on the pregnancy rate. If we use, for instance, hysterosalpingograph, then we found a hydrosalpinx, it's not as important as if we just found it directly during ultrasound without any fluid inserted. In hysterosalpingograph, we insert the contrast, and if only the hydrosalpinx found after the HSG is not as important as or as effect to the fertility compared to from the beginning we found it. Right, so in ultrasound, it's quite easy to see the hydrosalpinges by tubular cystic mass close to the ovary and incomplete septate. That's a classical view. In that case, we need to do clipping or taking out the hydrosalping itself, because we know the effect of this hydrosalping to the fertility is really deleterious. How about using only ultrasound to see the patency? Yes, we can do it by looking at the ultrasound with saline infusion to see the fluid before and after the ultrasound in the Douglas pouch. We can also use a high COSY or contrast sonography or high FOSI foam sonography, or we can also using the Doppler. By using Doppler, there is a specific pattern of the Doppler if the tube is patent or is obstructed. Now we can look at this, the pattern if the tube is patent, and the pattern of the Doppler flow if the tube is obstructed. But sometimes it's not easy to locate the ostium tube. That's why now in our practice, now we change into foam sonography. So we have a study on this high FOSI. I will show you how we do this. So this is how to prepare the gel itself. And this is the catheter. Here we use the transvaginal ultrasound while we inserting or administering the foam. Why we do with this foam is more advantageous compared to the previous contrast, because this foam stay in the uterine and the tube canal longer than the saline or the other contrast. So this is the video how to prepare it. This is the catheter. Then we insert the probe. Yeah, while administrating the contrast or the foam, you can see directly the contrast filled in the cavity, and in transversal view, right, in the tubal area, we could see the flow of the foam. Yeah, so our area of interest is between the ovary and the ostium tube. Here we can see that both tubes were patent, and we also found some adnexal mass here in the left side. So why we use this high FOSI? Because compared to HSG, the accuracy is similar, but acceptance of patient, I think that's more superior in high FOSI. We can look at this graph that the abdominal cramp, the backache, the bloating, the spotting is higher in the HSG group compared to the high FOSI. Right, this is the other way how to assess tubal patency during hysteroscopy. Here we use office hysteroscopy. Then we locate the internal tubal os. Then what we do, we create a bubbles by just flipping the infusion bottle so that small bubbles can produce. And by looking at this bubble flow inside the tubes, we can see, then we can prove that the tube is patent in one or in both sides. This is also originally published by Dr. Perry. Sometimes we call it as a periscope. And again, before and after the procedure, we see the addition of the fluid in the Douglas pouch, right? Now, by looking at this post-procedure of hysteroscopy, the presence of the fluid could give us more details on the structure of the uterus, structure of the adnexa, structure of the tube. Here we can see the ovary and the tubes by doing transvaginal ultrasound after hysteroscopy procedures. So I would like to quote Dr. Perry, who found this bubble test in fertile sterile last year. He said that though the uterus is a critical for reproductive goals, we often turn to less accurate and more painful methods than this gold standard. for evaluating the uterine cavity. For instance, we do a DNC, we do a PPEL, and so on. Then, if we look at the practice of reproductive and endocrinology and infertility today, it's weighed toward the eye. And the eye increasingly standing for in vitro fertilization or IVF, where the financial race for the ideal embryo may be overvalued when compared to optimizing where the embryo will spend most of its time, 9 months after fertilization, which is the uterine cavity itself. So why not we use this relatively low-cost opportunity to improve fecundity through an accurate, gentle, rapid, and safe office hysteroscopy that today is really underused, because it is impossible to effectively treat the pathology that one has not seen. So by having the eyes inside the cavity, we can treat the pathology. So again, I think I agree with what Dr. Perry has mentioned, that the use of office hysteroscopy in our fertility practice should be optimized. So our today's message, I think first, the use of ultrasound on fertility assessment should be more optimum. We use it for many situations that related to the fertility, the uterine structures, the endometrial structures, the ovarian structures, the blood flow, lots of information we can assess with the ultrasound. And the definition of unexplained infertility should incorporate office hysteroscopy assessment, not only ultrasound and hysterosalpingograph. And by combining these two examination, transvaginal and office hysteroscopy, we can have a safe, quick, and affordable fertility assessment, not only assessment, but also treatment by the capacity of the office hysteroscopy to treat many pathologies inside the cavity directly during the diagnosis. So that's my talk today. Thank you for your attention. Regards from my team in Rumah Sakit Cipto Mangunkusumo Hospital in Jakarta. Thank you.